Hello, everyone. My name is Dr. Yipeng. I'm the Associate Dean for Research at Illinois College of Optometry. Today, I'm very pleased to have Dr. Michael Chaglaysian and Dr. Ashley Spielberg join us to share their research insights. And let me give you a highlight about their research. Dr. Ashley Spielberg, just for the past 5 years, she finished more than 20 research studies and published 20 research abstracts and papers. And for Dr. Michael Chaglaysian, for the past 5 years, he published more than 40 research abstracts and papers. And since 2014, he finished 38 research studies. So after you hearing the highlight, now let's start the questions for Dr. Michael Chaglaysian first. So can you share with us your research experience at ICO and why it is so important to you?
Sure, thank you. Great to be here today and to talk with both of you about the research that I've been involved with at ICO for many years. So briefly, my research journey starts about 15 years ago when some of the medical device companies for OCTs started reaching out to collect what's called a reference database for the OCT imaging devices. These devices, in order to pass through the FDA, have to be evaluated and have a clinical trial with hundreds of patients across many sites, and that data is then submitted to the FDA, and the company or the sponsor of the device derives the reports that we use to evaluate our patient scans on. So that work started many years ago, and it continued on slowly with other companies joining and approaching me at ICO, primarily because of the population base that we serve here, the expert clinical staff that I could offer, like Dr. Spielberg, to join me in the studies, and of course the support from the dean and the college as the research continued to grow and grow. So as you said, right now there's a high demand for all new devices to get FDA clearance. That includes perimeters, tonometers, OCT devices, cameras. Soon it's going to be AI algorithms and other things that are coming down the road in optometry and eye care. And it's just been very rewarding to bring that to ICO and to show our expertise in this area.
Very well. And can you share with us what are the main research projects you are doing right now?
Well, still right now, mostly more of the same, unless I'm forgetting something that Dr. Spielberg can remind me of, but visual field testing devices, camera systems, OCT devices, new ones are coming onto the marketplace. And while the FDA has changed the requirements, initially some of the databases that I participated in and published on were like 350 subjects. Now it's 900. So not all 900 come from ICO, but I'm one of 6 or 7 or 8 sites. And we're working together with a clinical research organization and through IRBs to collect, these are healthy, normal patients, as we say, to evaluate the different OCT scans on the device, do all the analysis and the metrics with the assistance of the companies and their researchers. And that work goes on today.
So you mentioned 6 to 7 sites. When I think about how many optometry schools, right, in U.S., it's a lot. Why? And of course, you know, not just optometry schools.
Correct.
And ophthalmology practice.
Yep.
There are so many, and why they want you, Dr. Michael Chaglaysian, and they come back again. What make it special? Why they like you so much?
Participating in this type of research when it's a contract research and there's a corporate sponsor, there's a need to work efficiently and accurately and to be very nimble and to have a really sharp team. And for many years, particularly under your direction here, we've had the support of research and study coordinators. Now we have 2 full-time study coordinators, and that helps to deliver the product of the collection of data from the research subjects to the sponsor in a timely fashion. And typically at ICO, we can do it very somewhat cost efficiently, although there's a fair amount of money to be made here, quite honestly. So that's very helpful for the college and to the bottom line on our end. So we don't do it for free by any means. And delivering quality data is, as you know, essential in research. So that's what we've been able to do with a team approach through many investigators, not just Dr. Spielberg, but she works with several other faculty members on the projects that I brought to ICO.
So Dr. Spielberg, I have so many faculties. They mention that they want to do research, but it's harder for them to find a time to do research. And you have accomplished so much. What is your secret ingredient, and how can you be so productive?
Well, firstly, I think it's, doing good work when you decide to follow through, to sign up or help with a project, understanding, the ins and outs of what we're doing, being prepared and maintaining the momentum you have it when a study starts throughout the whole piece. The whole project can be challenging. As you get towards the end of any study, it starts to kind of wear on you a little bit. But maintaining that momentum so that ultimately we can get the data efficiently and then be done and move on to the next project. And a lot of the research that I've been involved in doesn't produce publications or papers right away. It's more after the fact, once we're kind of done and that data's been delivered to the FDA and they get their favorable outcome, then it's somewhat free for us to use and look at and put together ideas for publications. And so that's where some of the research comes in. So I would just say, getting involved, starting somewhere, because then everything else just kind of follows afterwards. I think recruitment's a huge part, so being very careful with recruitment and the way we talk about the opportunities with our participants so that they fully understand what they're signing up for, and they're always really excited to help, and I'm always very thankful to them when they come in and spend their time with us, to accomplish all of these projects. So that, none of this is possible without their participation. So exactly. Maintaining that good relationship. And a lot of our patients and participants, when they're done, they're like, call me for the next one. They have a great experience, and that's really helpful for the next project as we, continue on. We have sort of already each of us has like a personal list of okay, when we need disease, we got this is our starting block. When we need healthy normals, this is a starting block. And, and some of them have me saved in their phone, and they're like, hey, Dr. Spielberg, what you got for me? They're really excited to participate because they like knowing that they can contribute.
So I have heard this a lot, not, for you for sure, and for also other investigators. The research subjects are so happy with the study and the investigators, and they refer other patients to you and refer their family members, their friends to you. And they ask for, okay, if you have another study, remember me, I can come back for you.
Yeah, yes. That's a very important part of establishing the patient base of research subjects that I've accumulated over 15 years here is when the patients feel comfortable and trust the researchers and the scientists and the investigators, they are welcome to and appreciative of coming back for further studies. But I would also want to add, you asked, how Dr. Spielberg gets all of this done. And I have to say, for her and all the other investigators, it is just a huge time commitment. And so there's nothing that gets done in any research world without a lot of extra work, personal time, evenings and weekends,
exactly.
the dedication to get stuff done. So that's really the strength of our research team here at ICO.
Thank you. Yeah, I personally see how early, Dr. Spielberg, she comes for the research subjects and how late
Yep.
she stays.
It's nonstop. Like I was saying earlier, projects have to be delivered on time. And research projects notoriously throughout the ages have a tendency to go on and can be delayed. And when you're in more of the business world, projects have more real world deadlines, I think. Maybe I'm being a little bit biased there, but we work towards meeting those deadlines, and the whole team has to come together to do that. And so it's a very difficult balance for faculty at ICO. Yes, they may want to be involved in research, and then they sometimes get an impression of how hard it is to do and to the time dedication. And most all of us are doing this on our extra time, and we have this development time and things like that to get these things done. But that's what's critical, and that's what carries us forward to get more projects in the future.
That's the reason, all those different opportunities, they come to you, right? Because we deliver in such a high quality, very timely fashion.
I think that's part of the motivation sometimes is, you're really busy for a month or 2 months or 3 months or however long, but there's a finite end to it. And then if I'm between projects, sometimes I'm like, there's surely something else I need to be doing right now. But I think that's motivating, right? Because the more you can reach out to patients and connect and get people scheduled, the faster we're going to collect that data, and the faster you're going to have a little bit of discretionary time back again. So it's, I think, kind of a self-propagating loop a little bit for me.
A little bit of a thing I do where I put about 2 or 3 research projects out there at once, have everyone get really crazy for a bit, and then slow things down and allow them to focus.
Enough of a break that we're like, what do we got? What's coming up next?
Right.
We're ready again.
So you're pushing Dr. Chaglaysian to get involved.
But the stimulating thing is that when we are working collectively with so many different, let's say, companies in the imaging industry, OCTs and cameras and visual fields and devices like that, there's a lot of very interesting research questions that can get asked and then answered by us in research that is tangential and related to the contracted research that we do. And so that has grown a lot in the past 5 or 6 years, where the reference database that we work on, that gets to the FDA and is submitted, and there may be a white paper or a reference database paper that we work on. But then there's a number of other ARVO posters, Academy of Optometry posters, and other related scientific meetings where we can present this related data, asking and answering very important questions on how we take care of patients and what we do with these devices to determine if a patient has glaucoma or not.
Very good. So, Michael, one question I want to ask you, one thing I want to point out is your leadership. As you mentioned, you have a whole team, a lot of investigators. I do remember one of your studies, you had 27 investigators.
Yeah.
And you finished enrollment a total of 903 research subjects. 903 research subjects. And how did you do it to get so many faculties, investigators, even residents, your team?
Yeah,
a big study.
I think this was an exciting project. This was a one-of-a-kind type of project looking for the genetic basis of glaucoma disease in our patient population here at ICO. And it was for a company that was looking to validate the genetic testing that is still ongoing and still being worked on by others in the industry today. And so I think I don't know if it's motivation or just, get a number of people involved, realize that this is important research and it will contribute to the science and understanding of glaucoma. You have to have a project management plan so that the workflow for collecting the data makes sense. There's always hurdles and ups and downs with that as we fill out the documentation, as Dr. Spielberg knows, and the case report forms, and we have our study coordinators collect all of that. So you have to have sort of a big overarching plan, get a lot of people together, have a team approach just like you would with any large project, and keep communication open. And set the goals and expectations up front so that people know that, okay, if I'm going to join this project, I am obligated, as Dr. Spielberg was referring to, I have to recruit X number of patients of such and such type with the right inclusion criteria. I can't recruit these type of patients. That's my obligation to the study. I have to then, have a study visit with them, collect all the data, do all the documentation, and triple checking on everything that gets written down. And fit that into my schedule, because I'm not only doing research. Everyone here at ICO is doing many different things, wearing many different hats, and this clinical research that we do is just one of the hats that many faculty are wearing.
Just to give you some idea, for ICO we have 50 full-time faculty, and the particular study I asked Dr. Chaglaysian here is a genetic study in glaucoma.
Yep.
And 27 investigators were in the study. So my next question is to you, Dr. Spielberg. What kind of advice you want to give faculty in research?
I mean, I think if a faculty member is interested in looking to, get into clinical research, the first piece of advice I'd give is just jump in, like almost any project, because you learn more the more that you do. And as Dr. Chaglaysian said, when we're in the midst of these projects, sometimes these questions pop to mind that are not directly related to the study, but that we either have data we can retrospectively go back and look at, or data that we can use that's part of what we're collecting, after the fact to answer those clinical. And that's where then, you're working with a team of people, and now suddenly maybe you have 5 posters out of, one study and one data set, because there's all these different ways and different minds working together that come up with a slightly different question that we can use the data to answer, to look at in a different way. So I think I wouldn't want anyone to hold back and wait for the right study. If you're interested in retina and we need help in glaucoma, do a glaucoma study. You never know, and vice versa, kind of what the next opportunity is going to be. And the more experience you get, the more you build and become slightly more efficient with time management. You get your own sort of process for how can I recruit somewhat efficiently. There's always going to be hurdles and unexpected. So just organization and being planned with respect to, keeping your lists of patients who want to be contacted again. And I like to be really prepared for the day of the research visit when they come in, so that there's not a lot of downtime for the participant. They can come and, I'm respectful of their time, and they can go. And then, I've done a lot of prep work up front, and I'll do a lot of the, paperwork and stuff after the fact that they don't necessarily need to be present for, to keep the experience positive. So I think it's just give it a try, and you'll learn as you go. You don't have to have it all figured out beforehand.
Very well. So I remember when I joined ICO 2005, we did not have any clinical research space. Michael, you remember that, right? And in order for me to save my research patient, and I had to find a quiet exam room, which means either I started before the clinic or I see my research patient after the clinic. And later on, we had the research suite, and we had 2 exam rooms. And now we are in the research center, and we have 6 exam rooms, and we have pre-testing room. We have a big open area, multitask or multi-purpose area for research, and to look at how much, ICO, the research space grow. Do you see any, research infrastructure ICO should have, in order for us to promote research to make it easy for faculty to do research?
I think, I remember the research suite, and I remember, only certain people had the key card access, right? So it had a feeling of like, oh, only important people go in there, only certain people are allowed in that space. And our new research center, it's so open, anybody can go in there and they can see what's going on. So I think that's already one barrier down, is not feeling like it's restricted to only allowed individuals. But no, I mean, what we have right now is so much of an improvement. It's hard to imagine. I can't think right now of what could be added to make life easier, but maybe just a few more projects and I'll have some ideas.
Sure. A few more projects.
There are more projects coming.
Just to give you some idea, the reason we have to restrict the access to even to research center is because to protect the research subjects. The documentation, the research equipment, they have very strict criteria. And that's part of the reason. So my next question is for Michael and Dr. Chaglaysian. How do you see the ICO research grow? And do you see the research integral to ICO mission and the success?
It's always hard for me to predict the future, I think, and I'm always a little bit cautious, maybe more so than being optimistic. But things do continue to grow in the research area for ICO. It is definitely part of our mission, including students, residents, faculty is all part of our mission statement here at ICO, and that's important. I'm not sure, there's so many other things that we can get into in the future, particularly when you start thinking about some of the topics we're talking about now. AI, artificial intelligence, AI algorithms for identifying patients with certain disease based on fundus photos. We've done projects like that. We can talk about some data sharing and image sharing to work with other entities that are developing these AI algorithms. We don't have a lot of expertise in that area, so those are the type of things where I think the college needs to partner, and the researchers and the faculty have an opportunity to learn and to partner from other experts in the area. Maybe we have some expertise like that here, but I don't think too much. We need to learn a lot more about that. But that's where a lot of the research, I think, will be headed in the future. Some of the studies that we've done recently have looked at fundus photos and tried to predict cardiovascular disease, and do predict cardiovascular disease just based on the fundus photo. So those types of projects, there are already AI entities out there for diabetic retinopathy, as you know. So I think there's a whole world of opportunity out there. It depends on what the college wants to do and how much resources, because additional scientists, additional dedicated research time by faculty, that's one of the limiting factors.
Time.
Dr. Spielberg only has, 100 hours per week to give to me. So,
and you, Michael, always do it on your weekend or Friday night.
yes.
That's a peak time. So, Michael, can you share with us the main research project either you finished or you're doing right now?
So one of the projects that I've been working on for a few years here that takes the advantage, if you will, of the patient base of glaucoma subjects that we have here at the Illinois College of Optometry has been to look at clinical decision support systems. These are new types of modules that will identify risk and predictors of disease progression and development in certain types of patients. The goal is to guide a clinician to make a better and more accurate and more efficient diagnosis of glaucoma disease.
Just the diagnosis, or including treatment as well, and monitor the treatment?
Not so much on the treatment at this point. The work is still relatively early. Glaucoma, as you know, as a disease, has many different risk factors and many different data elements, from imaging and eye pressure measurements and many other things. So this started many, many years ago with a risk calculator that came out of the ocular hypertension treatment study, and is now evolving again to incorporate other pieces of information, such as the OCT scans that we collect on patients. The original risk calculator did not have anything like that. And so a clinical decision support system, it's just a generic term, a very long and difficult term, sorry that that's what's out there right now, would aid a practitioner in an office to make a determination of risk of glaucoma on their monitor, on a screen in the exam room, as they input information from their camera, from their OCT, from their tonometer, from their case history. And a risk score could come up sort of like on 0 to 100. 90 is, or whatever, is high risk of glaucoma. 30 is not, 50 is in the middle. And then that allows the clinician to more efficiently understand what the follow-up is and treatment or potential treatment and management is of that patient.
That's fascinating. That's really exciting. And I read your paper. And again, it's really exciting to see your research connect with clinic and really, help the future optometrist to manage.
It's definitely something I'm excited about. The other work that we've talked about here, the reference databases and all those other trials, very interesting, but not necessarily too novel or new. Important work, and great that we can have the patient population at ICO participate in those studies. It's so important for those studies to reflect the patient population, the population of the United States. So those reference databases have to include a very diverse population. And that's one of the things that ICO can bring to those databases. But apart from that, this other work on, risk calculators and health scores for glaucoma are a new thing that's not really out there. And partnering with the right entities and researchers could make it a world of difference for clinicians in the future to quickly assess who has glaucoma and who doesn't, because we're all going to be challenged by more data, more patients, less time, and these tools, like anything AI related, will be a help for us.
As you know, glaucoma is a silent killer. The disease does not cause red eye, itchy eye, painful eye, but can gradually remove the visual field to the end point and totally blind to patients. And so it's a disease, if the optometrist, ophthalmologist, eye care practitioner can diagnose this early, can definitely preserve the vision.
Yep. And on the flip side, because the healthcare system is facing the challenge with a great number of patients and an older demographic and an older population in the United States, access to optometry and ophthalmology and glaucoma specialists can be very limited. So the more that a general comprehensive optometrist who doesn't do a lot of glaucoma can determine that someone doesn't have glaucoma based on the risk score, then that patient wouldn't need to be referred on, through the healthcare system for a higher level, more experienced professional. So that saves cost, it saves time, it saves anxiety and worry, and that's part of the goal of working on these type of clinical decision systems.
Wow. So anything you want to add, Dr. Spielberg? No.
He said it really well. But I do think it's exciting. It's fun to be involved at this level, and I look forward to seeing how it evolves and what the middle and end and then future end, I guess, products are and how they can help. It's obviously going to help future optometrists, but also the patients, just make it easier for them to be properly triaged, for maybe lack of a better word, into risk categories so that, the system isn't burdened unnecessarily, but the right patients get the care they need before hopefully suffering significant vision loss.
Very well. And you may know that Illinois College of Optometry, all population, we see a lot of glaucoma patients.
We do.
And I'm not a glaucoma person. I'm a peace person. Occasionally I see those patients. It's devastating to see, how end stage the glaucoma already is. And it's challenge for clinician to manage glaucoma patients. And the research you are doing right now is really important.
Yeah, I think that, in my somewhat long career at this point, I think if you asked me 25 years ago, I would have thought that the diagnosis of glaucoma would be further along, meaning, easier, more accessible to people, more definitive. And I still, unfortunately, find too many patients falling through the gaps.
So in the gray zone you are talking about?
Well, yeah, it's just, there's so many reasons for this. So it's a whole nother discussion of why some patients across the country don't have good access to healthcare and eye care, and unfortunately present with later stage disease.
We are talking about, patients in U.S., right?
Correct. No, I'm talking about patients in this country and in this city.
Exactly,
Okay?
right?
And so, again, what I'm trying to draw the line to is that clinical decision support systems like this could be in place in many different locations. Maybe not just optometry. Maybe in primary care medical offices. Maybe in imaging systems with cameras that could image a patient anywhere. And it could be an early alert sign and a warning sign and a red flag for somebody who might not otherwise get to an optometrist or get to an ophthalmologist to be diagnosed with glaucoma. So that's the potential future of easing the burden of a population across the United States in many different demographics that are at high risk for blinding eye disease.
And especially your research to evaluate the risk factor maybe can have the alert early,
yes.
right?
Right.
And to preserve more vision and to alert the patients early instead of later.
Right. But the work is still that we're doing now is just to validate these very early stage systems to make sure that they are accurate. So you need a database such as we have here of glaucoma subjects and healthy subjects at ICO, and the system can be, quote unquote, validated or checked out in a safe manner so that it is, before it is released for general use.
Well, so any final comments you want to make or add?
No, I think I'm really pleased to be here at ICO and doing all this research and have such a great team and such a great leader and a research center. So it's been very rewarding for me.
Yeah, I think, I don't know, when I started on faculty, my drive was see patients and educate. And this is a little bit of actually a piece that I hoped I never had to be involved in early on, but that I've realized, isn't just sitting in a lab in front of a bench by yourself, but can involve interactions with patients. And then to see, our hard work and our time, then in someone's office and look, they're using that to examine patients, and they wouldn't have that information if it weren't at least in part for the work that we've done here. It's fulfilling on a different level. It feels maybe more broad reaching.
Excellent. I agree.
As you know, both Dr. Michael Chaglaysian and Dr. Ashley Spielberg, they are glaucoma optometrists, and they are very well known for the patient care, and also they do extensive research in glaucoma field, OCT device, visual field, genetics in glaucoma, risk factor for glaucoma, AI related, and a lot of exciting field in glaucoma and related research. Thank you, Dr. Spielberg, Dr. Chaglaysian, joining us to share your research insight. And I wish you good luck. With that, we are going to conclude our time for the interview. Thank you very much for your time.
Thank you.
Thank you.